is a Thoracic T5 667 interbody and posterolateral fusion for broken bone hyperkyphosis, and patient had a spinal cord stimulation device that wasn't really helping her. And I used the stimulation device actually for orientation and for leveling as well. You see the broken bone already, so we are going to go above and below that. We are orienting ourselves first, adjusting. First I put a screw in the K-wire in the 5 and take some bone marrow. Then we enter the 5/6 disc, perform a discectomy and prepare the end plate and put a cage. This is quite large cage, and I put it a little anterior to correct the hyperkyphosis. And here you see the discectomy, and then the cage is placed. The cage is 12 millimeters right at the front, and if you look carefully, some of the hyperkyphosis is corrected. And then we don't really take that dilator out. This is going to in the pleural cavity, putting it in and out produce more air or pneumothorax in the chest. I just move it from this level to that level with the blunt tip. That is how we enter. We enter the blunt tip, put it on the disc, then enter it with the K-wire, and then enter it into the disc with the dilator before a tube is placed. This is practically, we enter it now to the disc base. Now we enter the dilator inside of the disc base, and then a tube is placed. This tube is 10 millimeter outside, 8 millimeter inside, and now we have a safe passage all the way from the skin to inside of the disc. This is all blunt tools that doesn't put lungs at any danger. After we perform a discectomy, again we put another 12 millimeter cage here, as you see, and then I put a pigtail chest tube. After this is placed, here is the pigtail chest tube that is tunneled under the skin, goes inside and help us to manage if there's any air left. We obviously put a Valsalva to expel all the leftover air. And then the K-wires are placed. Here you see the K-wires in the 6 and 7. And after screws are placed, here where you see the screws are placed, then actually I remove the a rod is placed and bent to proper shape, and then actually at the end I removed as well the stimulation device. The post-operative chest CT, and I'm going to put a few views. This is the long view. During the process, patient had a hyper pressure, and when we did Valsalva, some air leaked to the chest wall cavity. This is look bad, but it really by itself is harmless. And here you see the lung is well expanded, and here you see actually the chest tube right here. That's called pigtail because it turns around. Now I'm going to show the actual hardware. I'm going to change it to the bone window that we see the hardware. Here we see that the screws in the 5, spacer well positioned here, screws in 6 and screws in 7, they're all adequately positioned. And again in proper window of the long window, you see that the chest tube is in good place, everything is well expanded, and no pneumothorax or hemothorax, as you can see here. This patient always get after this surgery immediate chest CT, and the chest tube is more or less somewhat prophylactic, but is necessary because we have to traverse in the pleural space, especially when patients has a low BMI. There are less tissue to seal the exposure, and they're more likely to get pneumothorax. So a prophylactic chest tube is very helpful.